they're actually one of my favorite procedures because, as you said, there's a lot of risk to them, but I think there's a lot of success. It's probably the lesion that the patient feels the best after you fix it.
Welcome everyone for another recording for MurmurMD. I'm your host, Sameh Sayfo, interventional cardiologist from Baylor Scott & White, the Heart Hospital, Plano in Dallas, Texas. I'm very honored to have Dr. Jay Mohan with us today. Jay, thank you for joining us today.
Yes, thanks for having me, Sam. Excited to be here.
So Jay is an interventional cardiologist at McLaren Cardiovascular Institute. He's the assistant program director of the McLaren Oakland Cardiovascular Fellowship Program. As an interventional cardiologist, he is also not only interested in complex coronary, but he's a stellar endovascular specialist. And today we're going to be talking about one of the most difficult procedure, in my opinion, to perform in a procedure that, if a complication happened, it's really can be a life or death situation. We're talking about an iliac artery CTO. So Jay, let's start with talking about how often the iliac artery CTO present to your clinic, what symptoms, and what's your workup for it?
Actually, when I first started, I was coming out of fellowship. I expected to encounter a lot of SFA lesions as the bread and butter for endovascular treatment. But, being a structural heart operator and also being complex coronary and in the age of mechanical support, I think I'm seeing a lot more iliac artery stenosis and CTOs that I'm being referred to for my partners. And actually, I think we probably do one or two complex iliac CTO cases a month, in addition to the standard ones that are severe. But they come in waves, and they're actually one of my favorite procedures because, as you said, there's a lot of risk to them, but I think there's a lot of success. It's probably the lesion that the patient feels the best after you fix it. And I think it's one of the lesions that you really have to have good pre-procedural planning before you try to tackle this thing. So it's not usually an ad hoc lesion that you would just fix on a whim.
What's your workup before? Is it an ultrasound, MRI, CTA, or just an angiogram?
So typically, when patients come to my office, I'm asking them the typical symptoms, claudication. With iliac CTO, they can present in a variety of ways, but most of the time it's buttocks or upper thigh pain, along with the calf claudication if they have that. And I'll usually just start with a routine ABI with a reflex Doppler. We're an accredited vascular lab, and that's typically the general workup. They'll get the abnormal ABI with PVRs that usually demonstrate monophasic waveforms throughout. And then based on that, we'll usually follow it with an arterial duplex, which generally will show low velocity waveforms throughout that affected limb. And then based on that and their symptoms, the next thing I usually do is a CTA with runoff, knowing that they're most likely going to have some aorto-iliac disease, and then that way I can pre-procedural plan them for intervention and also plan my access, because I think that's the biggest thing with iliac intervention is knowing where to go and where to put your sheaths.
You mentioned something very important. You said ABI with PVR. You didn't just say ABI. I think it's very tricky where sometimes resting ABI in those iliac occlusion can be normal if you have a large collateral. Is it traditional to do it PVR? Do you do it with walking ABI? What do you recommend? What's your recommendation? What are the hints that you maybe mentioned briefly before, but let's just re-emphasize them, that tells you this ABI, even though the number may be normal, but it's not normal?
I think that's the biggest thing. I think that a lot of providers make the mistake is they just look at the number. That 0.9 to 1.0 is actually still considered a borderline abnormal ABI. And I think those are the patients that for sure should benefit from some sort of exercise ABI assessment. Not all labs can do that. I would encourage your vascular techs to at least do like foot raises or something during the test to kind of provoke those numbers. But I think looking at the waveforms is the most important thing. So when you're looking at the waveforms, you're looking at diminished, your triphasic waveforms are gone, and your PVRs, they're all monophasic or blunted. And then you're looking compared to the contralateral side, you're going to notice a big difference with the waveforms, even though the ABI may be 0.94, 0.93, and some would say that's normal. But if you look at the waveforms, I think it tells you a lot.
You mentioned the CTA is important to kind of for pre-planning. What are the few things that you look at the CTA before you take the patient to the cath lab?
So I fortunately have been trained to read CTs. We learned it for cardiac, so I've really applied it to my peripheral training as well, and also for structural heart interventions. But I'm specifically looking at both those axial and sagittal views to see what's going on within that aorta and that iliac junction. A lot of times you'll run into this distal aortic syndrome, Lariche, or you'll understand, do you have bilateral common iliac involvement? How much of the external is involved? And then many times these patients have multi-level disease, including the common femoral segment. So that might be someone that you have to consider, as you do an angiogram. Can you intervene on the iliac and maybe do a hybrid approach where you're sending the patient for an ENDART for the CFA? So I think it gives you a lot. And I think the other big thing is CT is very sensitive for calcium. And I think it really tells you a lot about how calcified the lesion is and what tools you're going to need to use during your procedure to safely intervene on that iliac. And that's where I think IVL has really shined in the iliac space.
Iliac, if it's not a CTO, might be one of the easiest procedure to do. It's just same common femoral axis. There's no up and over. You just ipsilateral if you want to, but it may be deceiving for the young operator. What do you guide them? What are the possible complications that can happen? And what's your rescue toolkit that you have?
So I think one of the biggest mistakes that early operators make is they don't respect how calcified the iliac is. And sometimes you jam the stent up there, and you can have stent loss, or you can have stent malformation if you don't respect the delivery of the stent. That's one of the reasons why I do personally like going radial, or I like going ipsilateral and taking my sheath up and then desheathing the stent at the segment of the iliac, so that I'm not pushing that balloon expandable stent across the lesion where I may lose it. So I think that's one thing you should always kind of respect, is even though it may look like an easy lesion, a lot of times delivery of equipment can be challenging. And then sometimes looking at the confluence of the iliac bifurcation, if it's really steep and calcified, it's going to be very challenging to go up and over at times. So I think you have to understand that. And one of the things you risk is not only iliac artery dissection, which you can treat with a stent, but the most feared complication is any sort of perforation in that segment is a life-threatening and very, very scary retroperitoneal bleed that sometimes can be hard to control because, maybe you have a 6 French sheath in and you don't have that covered stent or that size available ready to go. So you have to plan for all of these things and really respect the iliac.
Perfect. And so what are your rescue toolkit that you always bring in to the room if you're doing any iliac? Just go through some of those rescue products.
So I think every iliac, in my personal opinion, the number one thing is you have to have a covered stent. You have to have a covered stent available. I'm doing a lot of TAS C, CTO iliac, so I'm using covered stents for treatment regardless. But having a covered stent in the room, even if it's not a CTO, extremely important. It's also for an early operator to understand that not everything goes through a 6 French sheath. So you have to remember that if you're using covered stents, usually over 7 millimeters, you're going to have a 7 French or an 8 French sheath in. So you have to understand that idea. I think every iliac should be IVUSed. I use IVUS routinely now in all peripheral interventions. And I think it really helps you understand the morphology of the lesion and then what to expect. And I think having multiple access points is another big thing. So one of the things I always do for iliacs is I have a radial access point, and that way I can always image and not worry about positioning of my stent without blindly knowing where I am. And then another thing I think is very underutilized, and I see a lot of people don't use, is the bright tip sheaths. I think bright tip sheaths in the iliac is a nice trick to use, because sometimes you're bringing down your stents, whether it's a self-expanding into the external, into that near the inguinal ligament. It's hard to know where your sheath is, and having a bright tip sheath I think really helps you in that regard. But I think having a plan, I think, is always the important thing whenever you're approaching an iliac, and understanding what your complication can be. But the biggest thing is understanding the use of a covered stent and the size difference that matters with the sheath size.
I think if you're doing a structural case and you already have a large bore axis, it doesn't really matter, because you already have a larger than 8 French at least. But I think for all the operators who are doing an iliac for the iliac's sake, it's very important to recognize that. I do a lot of radial approach for most of my iliacs, actually, for the exact reason you said. But people argue that if you do a radial and bleed, then you're in trouble. Actually, you're not. You can just balloon tamponade it, get your access, but you have to have groin access. You have to have a 7 French or 8 French ready. As you said, cover stent should be in the room, not somewhere in the lab. I appreciate your input on that one. Jay, you kind of led the way for us so far to talk about diagnosis, imaging, how dangerous this can be. It's not for the faint of heart, right? But let's talk step by step. Access, crossing, prepping, and intervention. Let's start with access. How many access do you need? Do you always use femoral? And what size sheath you want to have handy?
So based on the CAT scan, I usually know what I at least can expect, but there's many times the CTA is completely off, or it says severe lesion and it's actually a CTO. So I almost always go left radial to start. And I usually just start with a 6/7 slender sheath, and I just use a short sheath to start, and I put a pigtail down in the abdominal aorta, and I do an angiogram. And then based on that angiogram, then I decide what I want to do next. Sometimes I'll do selective iliacs if I need to with a 125 MPa, but generally a 125 pigtail tells you what you need to know. Then pending what that shows, I usually start by putting some sort of sheath within the affected ipsilateral iliac that has the CTO. So I'll get ultrasound guided access. I'll put a 6 or 7 French short sheath within the iliac, and then I usually do an image there as well as the radial, almost like in a CTO in the coronaries, where I can kind of see the full length of the occlusion. And then from there, I decide. Sometimes you have a very favorable cap, whether it's retrograde or antegrade. And so I'll usually at least attempt at going from the femoral to cross from the femoral first. And many times that's unsuccessful, just because that cap tends to just be a little bit more ambiguous, a lot of tortuosity in the external segment. And then the reason I do like that, though, is if you do get a dissection, it's against the direction of flow, and you can go up and potentially have a dissection to near the wall of the aorta. Not optimal, obviously, but it's still generally safe, and you haven't really created a problem at that point. But if I can't cross from the ipsilateral iliac, the next thing I usually do is I take a 119 centimeter R2P sheath and I park it at the cap within the common iliac from the radial. And then I take my microcatheter, usually an 035 and an 035 wire, usually either stiff angle glide or a glide advantage, and I try to knuckle with the microcatheter support through the cap. And once hopefully I cross from that ability, I usually externalize my wire through the femoral sheath, and then I'll finish the procedure all through the femoral sheath. And that's usually the next steps are, IVUS, angioplasty, and then plus or minus IVL plus covered stent.
Excellent. Just I think this is, again, for all interventional, there's a lot of different ways to do it. I think this is a really nice textbook. You have two axes, you're protected, you have all axis possibility. I think people are pushing the envelope. I do, as I said before, I like the radial. I go actually right radial, just protect my back. And depends on the case. Sometimes you can do it all radial, but again, we're talking about CTO complex. Don't be shy of getting a femoral axis. As you said, the biggest issue with the femoral axis, if you're not paying attention, you can start, even with the micropuncture wire, you dissect and you commit all to the aorta, and the last thing you want to do is to cross in the aorta. How often do you use Pioneer re-entry device in those cases, or any re-entry device?
You know, when I initially first off in practice as well as in fellowship, I actually used Pioneer quite a bit. It was one of my favorite tools for CTO, specifically for iliac interventions, because I think going from the femoral approach, you're getting near the aorta. It's an excellent re-entry tool. The problem I had with it was that it tends to be somewhat hard to deliver, and unfortunately, at times I would force it and break the IVUS component of it at times. I'm sure we all have done that. And there's also a lot of risk to it. You're sticking a needle out, hopefully, re-entering before the aorta, but there's also that risk, and also you're potentially could be partially subintimal, which I'm always trying to avoid. I've realized in any peripheral intervention is the more subintimal space you have, the less, patency rates are going to be worse. So that's when R2P really started coming, on the scene. And ever since R2P was available, probably like 2021, 2022, I started using it more and more. That's when my use of Pioneer actually went down quite a bit, because I actually found that the ability of crossing either from the ipsilateral or from the radial was very successful. Whether you went back and forth between the two, but you could always marry your wires at some point, or you could even do some reverse cart or cart procedure within the iliac space and actually re-enter that way. So my use of Pioneer has gone down. I still will use it maybe 3 to 4 times per year in an iliac intervention, but really radial R2P has really changed the game with that.
You speak my language. I'm a big fan of R2P, but one other trick for the audience, as you mentioned, you go from the radial, but sometimes you are in a dissection plane with a wire. That will give you another hint for the Pioneer, where you can see the wire and you direct your needle to the wire to try to avoid, entering or exiting the wall of the iliac. Crossing wires, you mentioned some of that, and then let's talk about, I think what a lot of people think is it was a game changer in iliac intervention. Let's talk about vessel prep. We can't use atherectomy. All atherectomy were not studied. Regular balloniolas with perforation. So IVL came to the rescue. Tell us your experience about using IVL from the M5 plus, from the M5, M5 plus, to now the L6. The difference between those, and what's your favorite balloon among all these three?
So I think IVL, just like in the coronary space, completely changed the game, because you're dealing with a very dangerous area to cause a problem. And that's why atherectomy in the iliacs is a class 3 indication. There really has never been anything proven to be beneficial within the iliacs, or more importantly, anything safe. I think IVL is the only thing that we know that can be successfully used. We were initially using the M5 Plus, but obviously you were limited by the size. And then I think the L6 really changed the game from a shockwave standpoint, because that really made us understand how we can adequately treat these large vessel iliacs, because they all are more than 8 millimeters, 8, 10, 12 sometimes, even bigger. And one of the things about lithotripsy is you really want to use the balloon as a delivery for the lithotripsy. It's not necessarily used for angioplasty or gaining of lumen from the balloon. It's for how do we get vessel contact, and how are we transmitting that lithotripsy to the deep calcium in the iliacs. And I in the structural heart space, I think is where it really mattered, because we realized we could change the vessel compliance of the iliacs quite a bit to deliver large bore sheaths, not even across tight lesions, but even with these really stiff stovepipe aortas and iliacs that really helped change the vessel compliance and help us deliver those. So I think the L6 from an iliac standpoint is my favorite. I think in the SFA, the E8 is an amazing device. I still don't have a lot of experience with the Javelin, but I think the Javelin is another really great tool, especially in the setting of an Iliac CTO that has a front emitting lithotripter that you can break calcium as you go. It's a nice tool as well in these chronic total occlusions within the iliac.
Thank you for that summary. And just for the audience, if you're going L6, you need 7 French or 8 French, depends on the sizing. Can you squeeze an 8 millimeter L6 or through a 6 French sheath? The answer is yes, we've done it. But also for the M5 plus, you can even push the 7 through a 6 French if you want to do radial cases and use IVL. Jay, what's your stent of choice for the balloon expanded stent in the iliac world? Do you always use a cover stent, VBX, or are you still using some of the non-cover stent?
So TAS-C or CTOs, very heavily calcified if it's not also involving the bifurcation of the external and internal, and it's isolated common iliac. I really favor covered stent. I use the VBX or the iCast. Both are very, very good. We also have used the LifeStream as well. But balloon expandable, extremely useful in the common iliac. And then, if it's a 80-90% iliac with a big gradient on pullback, sometimes I'll use a VisiPro balloon expandable. So I don't always use a covered stent, but many times when you're dealing with iliac CTOs, it's at the ostium of the common iliac, and many times you're going to have to do kissing covered stents. I think that's a very valuable thing to have is if I am going to end up doing kissing stents, I'll usually use covered stents. But if I have to cover or cross the external or internal, I'll favor something open cell more so like a VisiPro.
Can you tell the audience, just to summarize it, heavy calcified, cover stent, not heavy calcified, either or, crossing the internal iliac, you would like an open cell, which is non-covered. As everybody knows, or most of the operator knows, common iliac, you use a balloon expanded, external iliac, you use self-expanding. Can you explain to the early operators why not putting a self-expanding in the ostium of a common iliac? Especially you work also with structural world as well.
Yeah, I mean, so there's multiple reasons. I mean, the most common is whenever you're trying to, I hate using the term nail the ostium because we never say that in the coronary space anymore, but whenever you're trying to really be precise with positioning, I think using a balloon expandable stent is very valuable. I think you have more control with where you're going to deliver the stent. The other issue with the self-expanding stent in that segment is there's a potential risk of deformation of the stent, specifically that nitinol stent in future interventions or during your intervention that you're doing. But the most common thing I say, and this is supported in data, especially with the use of a balloon expandable covered stent, is I tell all my fellows a very important trial to read is the COBEST trial because it really demonstrated the benefit of using a balloon expandable covered stent, especially in TAS-C lesions. So these are these heavily calcified CTO iliacs because I think that the patency rate is going to be the greatest. And I think you need to know as an operator, you're not invested only in using the covered stent there. You can use a shorter 27 or you could use a short one and then use a self-expanding stent to cover the external. So you can kind of use it as a hybrid in both. I think you have to always keep that in mind. Don't get caught in saying I got to use a long covered stent just because you want to have one layer of stent there, because sometimes you have to overlap it with a self-expanding.
And just to add what you said, people need to remember that self-expanding will never get larger than the diameter you put in. Where a balloon expands, you can always expand it if you have to put let's say you're prepping the vessel for a TAVR or anything like that in the future, or EVAR, you can always post dilate the 8 to 11 or larger.